Okay, good morning everyone once again. My name is Dr. Margaret Gachanja and I work at Gachanja Level 5 Hospital. And I'm going to be taking us today through something we all know, that's classification and the clinical variants of psoriasis. And I wish to thank the organizers for this opportunity to present. It's an honor and a privilege. So in terms of classification of very broad condition with varied signs and symptoms among different patients, it is useful to classify the condition to help guide the appropriate treatment decisions. And this classification can either be in terms of the type, the evidence of pustules, pathogenetic cause, and body area and severity of psoriasis. So in terms of the types of psoriasis, this is actually based on the morphological presentation, what you commonly know as plaque psoriasis, generalized pustular psoriasis, dermatologist, palmaris plantaris, gouty, psoriatic arthritis, and inverse psoriasis. So this is basically based upon the morphology of the psoriasis presenting. Another one to classify is based on pustular classification. This is the evidence of pustule, so it can either be classified as either pustular or non-pustular. So my senior colleague, Dr. Kipena, will take us today over pustular psoriasis, so I'll just mention in passing. So pustular psoriasis can either be generalized or localized, and can also have a form called impetigo herpetiformis. Non-pustular, again, a repetition of the ones we saw before in terms of morphology, basically psoriasis that doesn't have evidence of pustules. Another one to classify psoriasis is in terms of the pathogenetic cause, and this is in two types. So there's type 1 and type 2. Type 1 is usually the onset before the age of 40. The person has a positive family history of psoriasis, and it's associated with HLA-CW6. Type 2, the onset is after 40. There's no family history of psoriasis, and there's no antigen association. Some cases of psoriasis are also associated with the use of some medication, and this is known as drug-induced psoriasis. So we can also classify psoriasis based on the body area, and this is a very common technique used in our practice. So it can either be mild, moderate, or severe. So when it's mild, it's less than 3% of the body is affected, moderate between 3 and 10, and severe it's more than 10. And again, this is an easy method to use, so it's basically used most in our daily practice. And for reference, the palm of the hand is approximately 1% of the body surface area. Another way to classify psoriasis is by the severity index. So this is also known as the PASI, and it's a measurement tool that is widely used, and it incorporates other aspects of the condition. So it assesses both the area of the body that is affected and severity of the lesions, and then it's graded between 0 to 72, whereby 0 is a healthy person without disease, and 72 is the maximal level of the disease. However, this scale tends to be more complex, so it's not used in everyday clinical practice. However, it is used commonly in research. So let's talk about the clinical variants of psoriasis. So psoriasis occurs in several distinct clinical forms, and various forms can be present in an individual at the same time. And all of the lesions tend to have common characteristics, as you know, erythema, thickening, and squamine. The size of the lesion varies from a small pinhead size to a diameter of up to 20 centimeters. And the lesions, the borders tend to be round, oval, or polycyclic. It tends to affect any region, but the most common regions affected are the knees, the elbows, the lumbosacral region, the scalp, and the genital area. So we'll start with plaque psoriasis. This is the most common clinical form of psoriasis, and approximately 90% of the patients affected have plaque psoriasis. And the lesions demonstrate a symmetric distribution, and it's clinically observed as erythematous plaques with sharp boundaries covered with pearlescent squamine. The common sites of involvement are the extensors of extremities, that's the elbows, the knees, scalp, buttocks, and the trunk. And predilection for these areas of involvement can be as a result of traumatic incident. The extent of the involvement can either be limited or involve majority of the body surface area. So those are images showing plaque psoriasis. So you can appreciate in the first photo, there is the erythematous scaly plaques on the scalp and the neck. Then the other photo, you can appreciate again well demarcated hyperpigmented plaques. In persons of pigmented skin, the post-inflammatory hyperpigmentation actually tends to obscure the erythema that you may see. So that's why it's not as evident as the Caucasian skin. These images show the first one on the knee, the coarse scale that you can see in psoriasis. And the one on the right, you can see the erythematous scaly plaques on the chest and the abdomen. This is an image also showing scaly plaques, and you can appreciate some fissures on the palms and the soles. This image shows large plaques with silver scale on the back. So this is just to remind us the common presentation of plaque psoriasis. Areas involved include the umbilicus region and the ear. So it's important during examination to examine such sites, and also the gluteal cleft is also an area that is commonly missed. So let's move on to gutted psoriasis. It's also known as eruptive psoriasis, and it's common in patients younger than 30 years, may present several weeks after group A beta hemolytic strep infection. And usually when you do antibodies, antistreptolysin titers, they tend to be elevated in this condition. It accounts for only 2% of psoriasis, so it's not that common. And it's frequently associated with HLA-CW6 gene. It presents with erythematous and scaly raindrop-shaped lesions that are 1 to 10 millimeters in size. This gives the name gutted, which actually means drop-like. So involvement is mainly over the trunk, the proximal of the extremities, the face, and the scalp. And usually with regression of the upper respiratory tract infection, the rash tends to disappear spontaneously within 3 to 4 months. However, it may actually progress and enlarge to become psoriatic plaque. And it's the type of psoriasis that tends to have the best prognosis. So those are images showing the gutted psoriasis. You can appreciate it looks like raindrops, as though someone has been rained on, hence the name gutted. So we'll touch a bit on pustular psoriasis, but this will be dealt with deeper by my senior colleague, Dr. Kiprono. So pustular psoriasis can either be localized or generalized. So the localized form tends to affect the palms and the soles, and the severe form, which is known as the von Zambusch variant, is actually more severe and has more widespread erythema, scaling, and superficial pustules. And also some of the causes that have been thought to lead to this pustular form of psoriasis include pregnancy, infection, or even withdrawal of oral glucocorticoids. So that's an image showing localized pustular psoriasis on the hand. This other most likely is the generalized form. You can see affecting the lower limbs, the gluteal region. There's this other form called impetigo herpetiformis. It's a rare form of psoriasis. Personally, I've not come across it myself, but it would be good to know if any of us have, and perhaps you can share your experience with it. So it's generalized pustular psoriasis occurring in pregnancy. So it tends to have erythematous lesions covered with pustules, which start and radiate from the flexural regions and have a tendency to agglomerate. It may gain vegetative character at the skin folds and tends to be very debilitating in terms of the patient can have lassitude, fever, shivering, nausea, and vomiting. So in terms of management, usually many patients tend to respond to delivery. Alternatively, you can give the patient prednisone, 1 milligrams per kg per day, and this also will contribute to neonatal lung maturity. So those are images showing the impetigo herpetiformis. That's an expectant woman at 27 weeks. And again, she presented at 37 weeks in the second pregnancy. So it can tend to occur in the first pregnancy, the second, or even start in the prepubertal period. So the next one is erythrodermic psoriasis. It presents with widespread inflammation in the form of erythema and exfoliation of the skin covering more than 90% body area. It is associated with severe itching, swelling, and pain. It may develop either slowly from long-standing psoriasis or appear abruptly in patients with mild psoriasis. And predominantly, you appreciate erythematous lesions. So the characteristic plaques that we see in psoriasis are not usually seen, and desquamation is not so obvious. The patient can present with hypothermia and other systemic complications brought about by desquamation that leads to protein loss. It is severe, potentially fatal, and it tends to be resistant to treatment. So that's an image showing the erythrodermic psoriasis. You can appreciate the confluence scaly plaques, and erythema is more prominent as compared to other forms of psoriasis with minimal scaling noted. So those are other images on the legs and the arms. So psoriasis also affects facial sites. We'll go through them one by one. So you can either have it in the intertriginous skin, the nails, the palms and soles, also the joints. So inverse psoriasis is also known as flexural or intertriginous psoriasis. It occurs mainly in the flexure surfaces, that's the perineal region, inframammary, axillary, inguinal, and intergluteal areas. The name is inverse because it's a reverse of what we know as psoriasis occurring in the extensor surfaces. The squamous lesions tend not to form distinctly because of friction and moisture in the skin folds, and they tend to manifest as bright red symmetric plaques. Fissures may also occur, and they tend to be malodorous, pruritic. Heat and trauma and infection may actually contribute to its development, and more often than not, inverse psoriasis tends to be misdiagnosed as either a fungal or a bacterial infection based on the areas of presentation. So those are images showing inverse psoriasis in the axilla as well as the submammary region. That's another image. In this one, you can appreciate the shiny erythematous plaques in the suprapubic region and the inguinal region. There's some minimal scaling noted in the scrotal region. So there's another form called napkin psoriasis. It's psoriasis occurring in the diaper area, usually in infants 2 to 8 months of age. And the lesions are brightly erythematous. They involve the diaper region. Tends to clear with topical therapy. However, some of the infants have psoriasis reappearing later in adulthood. That's an image showing the red erythematous plaques in the diaper region. Let's move on to palmoplantar psoriasis. This is involvement of the palms and the soles, usually symmetrically. And the classic presentation is usually erythema, hyperkeratotic plaques that may have associated fissures. And they tend to have very thick squamous, so tends to be confused as keratoderma. And the fissures tend to be painful and disabling, and usually concomitant nail psoriasis is seen. So those are images showing the squamous on the palms and the plantar region. You can see how it's very easy to confuse it with keratoderma because the scaling is thicker. You can also appreciate nail involvement in the plantar, in the toes in the image. So nail psoriasis is the other form of psoriasis. It's also known as psoriatic onychodystrophy, occurs in about 80 to 90% of the patients with psoriasis over their lifetime. The fingernails tend to be more affected than the toenails, and it's common in patients with psoriatic arthritis, about 80%. Sometimes it's actually the only manifestation of psoriasis. And the most common presentation of nail psoriasis is pitting. However, you can have other presentations like leukonychia, red spots, crumbling of the nail plate. There's also something called the oil drop sign, where a localized color change in the nail may occur. You can also have subangular hyperkeratosis, onycholysis, splinter hemorrhages, and this form of psoriasis tends to be resistant to treatment. So that's an image showing nail pitting in a patient with psoriasis. How to differentiate nail pitting in psoriasis versus atopic dermatitis is that the nail pitting in psoriasis tends to be more irregular, whereas the one is in atopic dermatitis tends to form a more regular pattern, almost in a line form. Those are images showing the pitting, psoriasis, nail pitting on the left, and then on the right you can appreciate subangular hyperkeratosis. On the bottom image you can see there is onycholysis and also discoloration of the nail. So let's move on to psoriatic arthritis. So it's a seronegative inflammatory arthritis with various presentation. The general prevalence is between 0.02 to 0.1%. However, in persons with psoriasis, it tends to rise to 6 to 42%, and it occurs mostly at the third decade. And the average male to female ratio is 1:1, and develops an average of 12 years after the onset of the skin lesions. So usually the statistics I found is that in 75% of patients with psoriatic arthritis, psoriasis onsets before the appearance of the arthritic symptoms, while in 10%, the arthritis comes after the emergence of the symptoms. However, in about 15%, it occurs at the same time. And usually, as I said before, usually patients with psoriatic arthritis, about 80% tend to have nail involvement. And usually the severity of the psoriatic arthritis is not related to the severity of the skin disease. And the symptoms commonly reported are joint pain, joint stiffness, especially in the morning, as well as back pain. Okay, here my time is up, so I'll just brush through. There are 5 clinical types. There's classical psoriasis, asymmetric oligoarticular arthritis, symmetric polярticular form, arthritis mutilans, and the spondylitic form. You can appreciate in the images the distal involvement of the joints. The next one you can appreciate, that's arthritis mutilans, which is a destruction of the joints. Other findings in psoriasis, just to mention, you can have sebopsoriasis, which manifests as red plaques with greasy scales. You can also have ocular features occurring in psoriasis that affects the eyelid, the conjunctiva, and the cornea. The most common presentation tends to be blepharitis, and uveitis may be seen. So the patient may present with ocular discomfort, flaking, crusting, swollen eyelids, and also psoriatic lesions may occur on the lids and the lid margins. There's also oral psoriasis that presents with fissured tongue. That's in about 6.5 to 20% of people. I have to admit, for myself, I tend not to look in the mouth, so I may have missed a lot of this, but maybe some of us tend to see this in the patients. So in conclusion, although the disease has many characteristic features, there is no established diagnostic criteria for cutaneous psoriasis. So there is no one unified classification, as we've seen in the presentation. And psoriasis tends to manifest in a wide clinical spectrum, and this clinical spectrum is not only to determine the severity or the course of disease, but it's also to guide us in terms of our treatment protocol. Those are my references. Thank you for your attention.